Good morning, everybody, and thank you so much for joining us. I'm Alicia Gonzalez, the Clinical Training Director here at Bridge, and I am so excited to have all of you join us for a conversation about how our patients have a right to medication for addiction treatment. They really have a right to emergency care in general, but they definitely have rights, laws, regulations that support their ability to access evidence-based, life-saving, medication-based addiction care. And I am joined by some experts who will introduce themselves in just a second. And I'm just really thrilled to be able to have this very timely and maybe detailed and interesting conversation about that. If you are not familiar with us, the Bridge program is a publicly funded institute underneath, a center underneath the Public Health Institute here in California. We were founded about 5 or 6 years ago. We do not have any financial disclosures, neither do any of our speakers today, but please be aware it is super common for us to slip and use brand instead of generic names. That's just because we're very used to it in our practices, what our patients say. So we might say Narcan instead of naloxone or Suboxone instead of buprenorphine. It's not to endorse any particular pharmacological company or brand. It's just what we're used to in our clinical practice, but we do not have financial disclosures. When California Bridge was originally founded about 5 or so years ago, our goal was to make addiction care available in every hospital in California by the end of this year. We are so close to that goal, but I would argue that since then, we have actually expanded our goal of making the Bridge model accessible to patients all across the nation, regardless of what state they're in. And we've had the privilege of working with patients and hospitals and champions in many different states across the nation as well. And that Bridge model is, first and foremost, making medication-based low barrier for patients. So medication-based treatment, meaning buprenorphine for opioid use disorder, maybe naltrexone for alcohol use disorder, but the patients could access that through any clinic, any emergency department, anytime that they're ready to start. So we want that to be very easy for them. And then also, though, that we really put dedication, some time into making a warm handoff from our clinical side into ongoing care in the community. And that might be outpatient care, like you'll hear from one of our experts today who works out in Arkansas, takes those patients and does ongoing outpatient addiction care. But we also mean navigation services and ways for our patients to generally connect and be supported by their community to deal with some of the root causes of what leads them to substance use in the first place, whether it's unstable housing, food access, that kind of thing. And then finally, building a culture of harm reduction. And to us, this is two separate things. This means, number one, dealing with the environment, the culture, the stigma that has surrounded substance use for a long time, but then also the practical harm reduction, meaning decreasing the morbidity and mortality of patients who use drugs. So can we find ways to prevent the spread of public health diseases like HIV or hepatitis? Can we help patients switch from injecting to smoking? Can we get naloxone out into our communities? Really reducing the harms, because we want patients to stay alive and as healthy as they can so that when they are ready to access care, treatment, that they're alive and ready for that. So with that said, I am just literally beyond excited to talk to our experts today about a topic that, again, I think is so timely. And when I'm thinking a lot about the legal and regulatory end of patient care, there have been a lot of uncertainties, developments, if you will, on the political and regulatory side. And I wanted us to spend some time diving into that and learning what does that mean for our patients who have substance use disorder. So I will ask each of my 3 panelists to tell me who you are, where you live, and a brief summary of the work that you do, which is really just like why I invited you here today. So let's get started with you, Elena.
Thanks, Alicia. Elena Lopez-Gusman. I am the Executive Director of the California chapter of the American College of Emergency Physicians. I have been the Executive Director for 17 years now, and it is my distinct privilege to implement and help our Board of Directors and our members execute our mission, which is to help emergency physicians provide the highest quality of care to their patients and their communities. And the bulk of my time is really spent in the legislative advocacy space, but really advocacy in general, which includes being here with you today. So I'm really thrilled to do that.
It is so exciting for me as a member of the CaliSIP board and somebody who's been involved for so many years to bring Elena on. I've learned a lot from her personally, and I cannot wait to see what she will share with all of you. Dustin, let's go to you.
Smith. I am a board certified emergency medicine physician, and also now board certified in addiction medicine. Still working in the trenches in the ER, probably about 8 to 10 shifts a month. But now I also have the privilege to lead Mercy's virtual substance use recovery program, which covers patient access to care at over 50 hospitals across Missouri, Arkansas, and Oklahoma.
And Dustin is somebody that we actually met when our Bridge team was doing a lot of work out in Arkansas. So he runs an amazing low barrier patient access outpatient based clinic out there. And we just are so excited to bring one of our national champions on this call. And then probably needs no introduction, but I will still let her introduce herself, Rebecca.
Hello, I'm Rebecca Trotzky. I'm a family medicine physician in LA. And I've been working with California Bridge since the beginning. And right now, my current passion is looking at how the juvenile justice system is supporting people with addiction access and have a lot of awareness and support for people who are immigrants in a variety of stages of that legal process and how people are accessing care in that way.
And Rebecca is one of our fabulous implementation leaders here at Bridge and has been with us for many years. So she's not an unfamiliar face to anybody joining us. But, I really want to kick us off by talking about the one law that I think probably is not going to be a surprise to any of you and is maybe the most recognized of anything when we talk about patients' access to care, like their right to access care. And that's going to be EMTALA. And so EMTALA, right, stands for Emergency Medical Treatment and Labor Act. It was originally passed by Congress in 1986, with its origins being more of being like a no dumping law. So the goal here was they had literally hospitals who would take patients with no insurance or who were underinsured, and they would straight up put them on a gurney and like roll them or send them in an ambulance to a lower income hospital and make that hospital deal with them, which is fully inappropriate and not good patient care. And so EMTALA was instituted, passed by Congress, and basically it requires that any patient seeking care in an emergency department, which includes, by the way, like a labor and delivery triage unit, so that's both considered emergency care, it requires that hospitals must provide an MSC, a medical screening examination, and any required stabilizing treatment for that emergency medical condition that is identified, regardless of their ability to pay or what their insurance status is. So it doesn't matter if you're honestly like a citizen or not, or what age you are, or if you can pay or not. Anybody who comes to an emergency department must be given a chance to have a medical screening exam with appropriate stabilizing treatment for any emergency condition identified. And so I want to emphasize those words for a second, which is stabilizing treatment for emergency medical condition. We at Bridge talk about this over and over, but to me, this 100% would include addiction care. We have talked many times, and we won't right now, about all of the data that shows that very high morbidity and mortality of patients who are actively in withdrawal or who are actively suffering from substance use disorder. And so those patients also have this right to stabilizing care. Dustin, when I met you, was last year back in Arkansas, you were the first person to pitch to me that EMTALA really is something that would guarantee a patient's ability to access medication-based addiction care. And you talk about it in a way that I'd never really heard anyone discuss it before. And I was hoping that you could walk me through that argument that you made for me a year ago. How does EMTALA guarantee a patient's right to access medication-based addiction care?
I appreciate you bringing up that topic. And I think about this mindset as kind of being the stick mentality for convincing our colleagues to do the right thing. My hope is that by the end of this conversation, we can just be providing great care to our patients because it's what we're good at doing. But ultimately, this outline was from a document that I reviewed from the Legal Action Council, 60-page document outlining how the practices that I probably had as an emergency physician early on, and some of our colleagues still do, are not meeting the standard of care. So that's meeting a patient while still on the gurney and offering them, an AMA form, allowing a patient to rip out their IV and leave without having conversations about how medications can be helpful, claiming that you evaluated the patient and they were stable to leave without offering them medications in the department, without offering them prescriptions, without having a discussion or documented discussion about Narcan, and ultimately trying to encourage that patient to engage in treatment. Ultimately, all of those things should be a relatively quick conversation if you are maybe getting the impression that the patient doesn't want to be there or is too uncomfortable. But that conversation does carry weight. Our patients do hear it. I can't tell you how often we've heard from colleagues in the ER who had these conversations. The patient said, no, I don't need that. I don't need any help. Who then within 24 to 48 hours are engaging our virtual service to enroll in care. And singing the praises of the ER doc who was at their bedside, who offered them that compassion. So Not only is it the right thing to do, but ASAP worked really hard in the advocacy world to make sure that we're appropriately reimbursed for those efforts.
Yeah.
Identifying disease, offering medication where it's appropriate, offering a script, and offering or coordinating a referral. Simply offering a list of resources and telling somebody to get their phone out and start calling, it doesn't meet the standard. So if we're doing those things well, our patients are going to do better, and we're going to have less of those conversations where somebody comes up and says, hey, remember that patient you took care of yesterday? So again, I don't want to scare my colleagues into making the right decisions, but that's one of the things that I want to try to avoid in my career.
Yeah, what I hear you saying in a couple of ways is that, when we know that we have identified this emergency medical condition and we know there is a treatment, if we do not offer that treatment for the patient, that's like, it's basically malpractice. Like, it'd be like if I saw a patient with cellulitis and I didn't say, hey, my recommendation is antibiotics, right? If I said, hey, looks like you have an infection in your leg, that one bites, man, good luck, right? Like, use some cold ice packs and I hope it goes away. Like, it is not the standard of care. And so when we have a medication that we know is the treatment, which has been proven over and over to decrease morbidity and mortality of that substance use, if we don't even offer it or have a conversation with our patient, we're not meeting the standard. That's basically what you're saying, I think.
Absolutely. The more that we can convince our colleagues to equate denial or not offering care for medication-assisted treatment to other things that we do very well, the better we will get, the more comfortable we'll get at this. Again, emotions that are provoked with certain diagnoses. Imagine that STEMI EKG being handed to you and then turning to the patient saying, well, if you would have quit smoking and controlled your diabetes, this STEMI wouldn't have been going on, and then not hitting the easy button for the cath lab, right? Same thing, TNKs or TPA, whatever your shop is using, not offering antibiotics. It's equal. And the unfortunate equality there is that we do know what the standard is, but in this particular disease process, some of our colleagues are still saying, oh, this is a moral harm or a personal decision. The reality is so many things that we take care of in the ER are associated with some type of addiction, but we still hit that, STEMI button and activate and get the right people on board, whether that person had a smoking history, whether that person was drinking alcohol before they got in their level 1 trauma. We still do the standard of care because that's what we're trained to do. And we shouldn't sort of piecemeal about when we are going to do the best care because of our own either lack of understanding or inability to acknowledge that this is worthy of our resources.
Yeah. And I love that you mentioned the lack of understanding as being a thing that is an excuse, right? Because we definitely have all heard physicians say, well, that seems hard, that's complicated. I think in preparing for today, all of us were reminiscing about the X waiver and how that did not do us any favors. It was like a gift of an excuse to present this fake fog of discomfort. Like, oh, well, it's so complicated to do, say, buprenorphine for opioids that there's this special license and I can't do that. But, that is gone now. And in addition, you mentioned TPA and TNKs, right? My hospital that I work at recently switched, I would say in the last couple of years, from TPA to TNK for strokes. And we all had to undergo training. Like, there was no, oh, I don't know that medicine, I can't use it. It was, well, then you better learn how to use it because this is what we're doing. And I think, you also mentioned ASAP and the ability to bill for it. Like, you would have no legs to stand on since the DEA now requires everyone to certify that they have completed 8 hours in education on addiction and pain management. And then ASAP says this is a billable procedure, meaning it falls underneath the normal scope of practice for an emergency physician to the point that you should be able to bill for this like a suture repair or like a joint reduction. That if you were a clinician out there who says, well, I don't really know how to do that, that's on you. And I think, can you tell me a little bit more, Dustin, about that document you were mentioning? Because what you were sort of telling me was it was like a secret into what the lawyers are already talking about. Can you tell me what was in that document that made you think this way?
Yeah, I mean, they outlined all of our previous practices, right? Like, I'm having bad flashbacks to one of the times when I decided to start advocating more for folks with substance use treatment. I handed somebody that standard, like, dusty file list of resources that's been, recopied 30 times, kind of crooked. And the guy asked me where I was going to tell him to go. And I said, well, why don't you go to Clinic X? And he just kind of rolled his eyes and said, they don't care about you down there. And it was because that those patients, when trying to go to those clinics, were often not ask what their name or drug use issue was. It was, what insurance do you have, or what do you have an ability to pay for these services? So that's where it really does land in our into our on our plate. And so the document basically outlines, hey, did you give them an AMA form? Yeah, that's great. But did you acknowledge that they were in a state of distress because they had just received Narcan or were in a severe state of withdrawal? Oh, you didn't do vital signs, or their vital signs showed that they were abnormal. Again, it sounds like, I don't know, as an ER doc, we should be stabilizing unstable or abnormal vital signs. Did you, while they were in withdrawal, offer them medication that would have made them feel better? Or while they were still under the influence, talking to them about how to initiate that medication in the future? Hey, they had just overdosed, they're feeling pretty sick. What's the likelihood that they're going to go back and potentially use again if they're feeling uncomfortable? So did you talk to them about having a script for Narcan? So basically just outlining all those things that, again, are part of the G2213 reimbursement code, that if we don't do those things, they're going to use it as a kind of leverage to say, this is what your colleagues are doing. Why aren't you doing that? So I think, to the credit to the docs who maybe aren't making this part of their practice, I think it's often fear-based, right? They're fearful that one of their colleagues is going to say, oh, you're practicing out of the scope of this department, or all of these patients are going to come here. Or even worse of all, I never had the opportunity to use this medication in residency. And so many of us have our standards because we used it 73 times in residency. And so if you're out in practice now and your shop has not used it, or you weren't trained on it, then it could be a little fear-inducing. But the reality is, when we see somebody go from a state of suffering to feeling normal again, it very rapidly makes us more comfortable in making this part of our practice with a sort of see one, do one, teach one mentality. And then we can just acknowledge that we're providing the best care, rather than having these persistent fears about how EMTALA is going to be leveraged against us.
Definitely. And if you're watching this webinar and you are interested in looking at this document yourself, we'll throw it in the chat, but it was from the Legal Action Center, and it's actually called Emergency. Hospitals are violating federal law by denying required care for substance use disorder in emergency departments. And I want to read this one quote to you, which will actually kind of help us transition to our next law that I want to dive into. But there was this quote that says, hospitals could be liable for violations of EMTALA, the Americans with Disabilities Act, and the Rehabilitation Act of 1973, and Title VIII of the Civil Rights Act of 1964, when they fail to adopt evidence-based practices resulting in patient harm. And then basically this legal document takes those laws and goes through them all and says, if you are not making this the standard, you are now opening yourself up for a legal liability. And I agree with you, Dustin. I never want to use the sick as the way to get clinicians to do the right thing, but I do think it sometimes can be the impetus for somebody who has been uncomfortable for whatever reason. We all bring our own personal histories to our care of patients with substance use, but the time has come. The time has come for all of us to do the right thing, the legally binding thing, the morally, ethically correct thing, and the medically right thing. But one of the other laws that was mentioned in that quote, right, is this American with Disabilities Act. And the American with Disabilities Act, for those who are less familiar, is really in place to eliminate discrimination by requiring both state and local government programs and, quote, places of public accommodation, which multiple times has been argued to include hospitals and clinics, by the way, but places of public accommodation, to treat individuals with substance use disorder and with many other disabilities, both equally and fairly, based on an objective evaluation of their qualification for services, instead of, you know, maybe our stereotypes or some of the moral feelings that we have, like, well, you shouldn't have been smoking, well, you shouldn't have been whatever. Like, that's not really in the law, our opinion of people's choices. So, Rebecca, I actually want to shift to you for a second, because you're somebody who has mentioned to me that once in a while, the ADA can be a helpful way to defend patients' access to certain kinds of care. Can you elaborate on that a little bit?
Yeah, it's been sometimes a challenge. And so I work more as a hospitalist these days than in the ER. But when we're looking for disposition plans, or somebody's coming into our care and we're trying to return them back to their place that they came from, whether it's a nursing home facility or a housing unit, oftentimes there's a barrier to care that can be perceived, where they're like, well, we can't possibly accommodate blah, like this kind of mobility device. Or it could even be, our care means that you can't be on a controlled substance, and buprenorphine is a controlled substance. So therefore this person can't return to their housing or be eligible for this housing program. And it just is, such a challenging thing, because you kind of understand why, okay, well, why they might say that, but it's really imperative on us clinicians to say, look, buprenorphine is safe. Yes, it's a category of disease that we don't consider often as a part of the ADA, but substance use disorder, behavioral health issues, all those things fall within that class. And sometimes when you're getting pushback from a facility, oh, we don't take that kind of patient, we don't take that kind of issue, to just say, well, what kind of issue are you specifically talking about? Like really get them to put in writing what they're talking about, and then say, hey, I'm concerned that this could violate, some ADA thing, and how can we work together to make sure that your facility feels comfortable and confident caring for it? Is it information? Is it, understanding that you have access to a clinician who can support you through that transition of care? Is it, what is it exactly? And then really kind of working collaboratively to address that barrier. And, sometimes it's a particular case that, you talk to the front desk staff who's screening for eligibility and they don't understand, and then you're able to train and then things change. And sometimes it's kind of working up that care. You're talking to a CEO or some medical director of a facility, and they're supporting your work, and then they're helping their staff understand. But really just making yourself available for those longer term conversations in your community. And we have seen, this reduce a length of stay in the hospital or a length of stay in ED obs while we're trying to find a placement for somebody who needs some sort of disposition plan or care plan after.
Yeah, I appreciate that you always say things with a very careful lens of collaboration, because nothing that we're saying in this webinar is meant to be like run around and go threaten people. Like that's not ever an effective strategy. But I do think you're emphasizing an important point, which is you do have to know, though, what those protections are and be able to invoke them in a conversation to achieve the good. And so saying, hey, I'm concerned that this particular limitation that you're imposing may violate this law. Like maybe we could work together. What's the piece of it that makes you all concerned about that type of patient? Can I be available by phone for you? Can I refer you to, this addiction specialist? Can I get you a backup person so that you don't feel uncomfortable with that anymore? But using that law to sort of drive a conversation forward, in which case maybe somebody wouldn't want to talk to you, but not because you're threatening them like, I'm going to sue you, over the ADA. It's more like, oh, this sounds like it might not be in line with MTELA or the ADA. Can we talk about how we can achieve the right thing for our patient? So always keeping that at the center. I appreciate your lens on that. And speaking of, this is going to be a sloppy transition maybe, but in my head, it makes sense. Like speaking of things that maybe don't always feel comfortable to talk about, I would love for us to do the difficult thing, which is to talk in a thoughtful way about immigration. And the reason I want to talk about it is that it is not a secret to anyone that the current administration has made a priority of, decreasing the amount of immigration into the United States, and also increasing the amount of deportation of people who are currently here and are undocumented or are not here yet lawfully or legally. When that first was happening, those changes were happening, we were getting a lot of calls and questions from very concerned clinicians. So by means of background, right, ICE, which stands for the Immigration and Customs Enforcement, that is a division of the Department of Homeland Security. Previously, it was not like a law or a rule, but there was a memo, an internal policy, if you will, at ICE that was put in place that asked ICE, the immigration officials, to generally avoid conducting enforcement activities in like arrests or interviews or searches in what they called protected areas. And in the protected areas list was like elementary schools and also hospitals. And so it was basically a discouragement of ICE officers to use hospitals as a place to perform immigration related activities. And then in January, on the 20th of January this year, 2025, this policy was actually rescinded by the Department of Homeland Security. And that is when a lot of clinicians started coming to us and going to their, organizational societies in medicine and saying, hey, I'm really worried. Like, what the heck? In my hospital, for example, I work in a border town here in California. A ton of my patients are actually Mexican citizens or otherwise, and they come into work and they go back, or they come and they stay. And it is a big question that was coming up around me of, well, what do we do? What happens if ICE comes here? And that also just got me thinking in general about patients who are under law enforcement, period. Like, what about patients who are here with correctional officers, patients who, maybe just recently committed a crime that was a violent crime, they got hurt, and now they're still my patient, and the police are here. Like, we take care of very, I would say, politically complicated patients, but to us as clinicians, we are trained that we care for every patient every time, and that all of that is just noise, that is not supposed to inform how I care for this individual, that I would provide the same medical screening, the same testing, the same stabilization, the same intervention for any single person, regardless of citizenship, criminal status, did you commit a crime or not? Are you a child or an adult? Can you pay or not? Again, I'm Tala, like it doesn't matter to me. I was trained to take care of everyone. So it does make sense to me that clinicians would be worried in general about what does this mean? How is that political movement going to interface with my ability to care for my patients? So, Elena, you are somebody who I find maybe the most thoughtful, if not just one of the most thoughtful, at being able to articulate these kinds of concepts in a way that I want to be honest is apolitical in the sense that we're not taking a side. This is not about us being liberal conservative. It's about us being pro physician patient relationship. And I was hoping that you could offer your advice, your insights, your thoughts about this subject, having been hearing these concerns from clinicians and being on the more legal side of things.
Sure. I mean, I think, first we have to acknowledge that it is scary times because they are uncertain times, and uncertainty breeds fear, right? As human beings, we like to know what we're going to face. And I think, we're living in essentially an intentionally chaotic time. I don't think it's an accident that, you can't predict a whole sort of things in society right now. And that's intended to keep people unnerved. And so I think the first thing to do is to, acknowledge that that's real, that's unfortunately, I think on purpose for us to be all afraid, but also then to take a deep breath and, try to ground yourselves, which is, what you are, exceptionally good at as practitioners in the emergency department setting, right? Is there's a whole bunch of chaos and you find a way to stay grounded. And so I would say first and foremost, to call on those skills in this same setting. We haven't seen in those protected spaces, like you said, schools, churches, hospitals, we have not seen ICE raids. That doesn't mean they couldn't happen. It just means to kind of temper the fear with the current reality, right? And so to approach it from that perspective. And then I would say, how do we prepare ourselves? How do you prepare yourselves for what could potentially come, right? And I think, that falls down in a couple of different categories. The first is if ICE were to show up in the emergency department. At this point, since there was a whole flurry of activity, most hospitals should be prepared for this now. There should have been a conversation dating back for a couple months, and hospitals should have several people actually, so that you have 24/7 coverage. There should be somebody who is designated to be the interface with ICE. You should all find out who that is in your hospital if you don't know who that is already. And they should be the conduit for any kind of communication. And then a couple of other things to keep in mind. And this is true, you mentioned other law enforcement, but this is true for law enforcement in general. There is essentially a public part of the hospital, and there is a private part of the hospital. And what law enforcement has access to in each of those settings is different. So they can walk in just like any other member of the public into the waiting room or into, the outside of the ambulance bay that's on the curb. Those are public settings, right? The private, and I realize not all patient care is very private anymore in the emergency department. But, what is considered patient care areas, they do not have access to without a warrant. And again, so if they're, and I realize that, there are studies actually about the impact of law enforcement in the emergency department on clinicians and how clinicians are intimidated by them too. But to the extent that you can feel empowered to say, please wait right here, let me go get the appropriate person, they do not have the ability to go into those patient setting areas without a warrant. And so you absolutely have the right to say to them, please wait right here, let me go get the appropriate person. You do not have to give them access, nor should you give them access to patient care areas. If for no other reason, it's disruptive to patient care, whatever they're going to do, right? That's just not in the best interest of all the people that are being treated there. It's intimidating, it's disruptive. And so, they can have access to a patient area. They don't have access to a public area. They don't have access to a patient area without a warrant. And they can question people, but just like if you were on the street, everybody has a right to deny questioning, right? You have your Fifth Amendment right to say, I refuse to answer that question. And you do not have an obligation to turn over any medical records. Again, that's why you want to get that other person involved, because they'll know if there's a warrant, what has to be turned over and what the process is for that. That seems, hard to imagine that law enforcement would come in with a warrant, right? Even in the instances now when you practice, law enforcement is usually there with a patient that they've brought in, not serving a warrant, right? So,
Right. Yeah, I really appreciate you putting that into some perspective, that while there was a lot of fear, there was not this like mass showing up of immigration officials in emergency departments that we have seen nationally. It's just not being reported. And also that always, right, through our lens, I don't ask my patients who are here, say from the prison, like I take care of patients from our local prison. I don't say, yeah, so what are you in for? Like that's it's just like not a part of my interaction with them. And that I should feel empowered to talk to that patient and give them privacy and make sure that they're not, for example, being interviewed in a lobby because we don't have a bed. Maybe we figure out where can we make sure that every patient at least gets an interview behind a closed door so they can say whatever they need to say, to fully disclose their medical concerns to me. That's really that distinguishment of public spaces versus private patient care spaces. And then I think also freeing us, the clinicians, of that burden. Like it's not being, part of a resistance or something to say to an official, that's really not my job. I apologize. Could you please wait here? I'm happy to get the person who will help you with that. That is appropriate. That is not political. That is not our job. We should not ask our clinicians, our bedside nurses, our doctors, to be managing those levels of politics. And like you said, it is disruptive to patient care. I don't have time. I don't have time for that. I'm so busy, like doing my other stuff. And then you mentioned, so for example,
there's not even room for an extra body.
Yes, yes, I think they don't fit. There already are no chairs. Sorry, dude. But what are some other like tangible pieces of advice? I know you had advised me even early on about like documentation or things like that. Are there any other pieces of advice that you could offer to clinicians? Like, what should you do in your practice, or what should you know besides who to call, and that it's not our job to get involved in that? Just take care of the patient, do your job, and let the appropriate people do it. Like, what documentation recommendations or other thoughts would you share?
Yeah, so I sort of said there's kind of two ways that this comes up. The first is if they're physically present in the emergency department. The other is what is, I guess, physically present in the medical record, right? And so, how you approach documentation and, immigration status, thank you, EMTALA, actually, is not relevant to your care, right? So you don't need
Yeah.
to know about it. You don't need to ask about it. You're required to take care of the patient regardless. And it doesn't have any medical presentation, right? It is not going to affect your clinical decision making. So it really has no role in your mind, and certainly not in the medical record. So you don't need to ask it, you don't need to know about it, and if you know about it, you don't need to document it because it's not relevant to the clinical care that you provided. And so that just keeps things cleaner, right? I mean, we don't know if medical records are going to be accessed, but if you don't have it in there, then we don't have to worry about it, right? And then you don't have to feel any thing about that. And again, it's not relevant. So it's just, it's asking questions you don't need to know the answer to as you're, triaging the situation. So
Yeah, I love that that's a reminder to me in some ways. Our medical charts have been co-opted by so many other entities. Like we get subpoenaed to be witnesses in court cases and have to read our notes. The billing company is dissecting our notes. But in the beginning, the point of the note was to communicate medical issues to other clinicians who will then care for this patient. And so if we just keep our focus on this is a clinical record of care, a lot of these things are so irrelevant. It doesn't matter if this injury happened while they were crossing a border wall. It doesn't matter if they're a citizen or not a citizen. It doesn't matter if they're in custody or not in custody. Like, those things may be relevant. And if they are, then we can navigate that carefully. But most of the time, they're not. I want to keep you in the hot seat for a second, Elena. Oh, and I forgot to mention this, but if anybody wants to see an example, if your hospital does not have guidelines for what to do if you are interacting with the Immigrations and Customs Enforcement, the American College of Emergency Physicians, ACEP, did put out a set of guidelines that are pretty vague and kind of thoughtful and just walk through these steps. For example, knowing what a private versus a public care space is. It can be a really great resource for clinicians. We threw it in the chat, but that's available to you, obviously, online. But Elena, I do want to keep you in the hot seat because in part of this conversation, you mentioned like patients' privacy and the idea that none of that changes, that like all patients, again, thank you, EMTALA. One really good thing is that it does protect all of that. One thing that comes up for our people a lot is this idea of this law called CFR 42 Part 2, which is a part of just like a very detailed, nitty gritty, down in the weeds thing. But we hear a lot about, quote, Part 2 compliance. I think we're all very familiar with HIPAA, the Health Insurance Portability and Accountability Act, which protects patients' medical records. You have to have like subpoena them. You can't just like randomly call and say, hey, I want to know somebody's medical records. You can't open their chart if you're not part of their care. Like all these things that do protect our medical privacy. But this like Part 2 compliance has been a thing that we have seen cause barriers and complicate patients' access to care. So I was wondering if you could walk through what the heck is that for a minute, and what does it actually affect? Like, what does it mean practically for us in the emergency department or even in the clinic? And what does it mean for us caring for patients? How do we comply with Part 2, and what does that even mean?
So the FR in CFR is federal regulation. So it's a federal regulation. And while you all may experience it as a barrier, and we'll talk about, what that is, the intent of the regulation was to protect the privacy rights of individuals with substance use disorder. And so it was a well-intended regulation. And it was really intended to protect against, recognize that there is stigma around receiving treatment for substance use disorder, and therefore to protect patients' privacy. So that's where it comes from. And so it essentially requires some additional barriers or additional steps like patient consent to share information. Because the idea was that you didn't just want this information out there willy-nilly, letting people know that this person has substance use disorder, right? Or they're being treated for substance use disorder. So I think, think about it, the layers. The first layer is like, well, where does it apply? And because it was intended to address stigma, it applies in places essentially that hold themselves out to provide this unique kind of care. So a facility that identifies itself as providing this care, or an area within a facility that provide, like a dedicated, like the children's hospital wing of a hospital is dedicated to, right? So if you have a substance use disorder that's advertised essentially, not just bed 3 on floor 2, right? But like a dedicated place, and then also dedicated staff. So people who exclusively do this work, right? These are like ORs, these are the tests for whether it applies. So a whole group of people that only do substance use disorder treatment. So guess what? The emergency department is none of those things. The emergency department treats all kinds of people, as you well know, every sort of thing under the sun, right? And you all are folks who are specialized in treating every sort of thing under the sun. So none of those criteria apply in the emergency department. You are not a Part 2 entity. And so emergency department to emergency department, you do not have to comply. I think the question really comes into play when you're trying to place somebody potentially somewhere else that might be Part 2 compliant or thinks they are Part 2 compliant, right? And I think it goes kind of back to what Rebecca was talking about earlier with the ADA stuff. So knowing where they're coming from, why they think they need that, and trying to go through those barriers to get your patient the care they need. You might argue, you might know now that you know this, that it's just an inpatient bed in another facility. It's not a specialized unit. And you might say to them, hey, you don't need this additional patient consent, all the additional documentation. Are you sure about that? Or you might recognize, oh no, I really am transferring this patient somewhere where they need this care. And so therefore I do need to jump through these hoops. But, at the end of the day, the true north is the patient care, right? And so that's where you want to get to. And, and there are some instances where, it might not be required, like I said, but, that hospital has made the determination that they're risk averse. And so they don't, they want to follow, cross all the T's and dot all the I's. They don't care if it applies to them or not. And you all are a bunch of folks that are not risk averse, thank goodness. But hospital administrators are built with different DNA. And so, you just kind of have to respect where they're coming from. You can try to get them where you want them to go. But at the end of the day, do what you got to do to get your patient what they need.
I love that reminder that while we in the ED are not risk averse and are very privileged to not have to worry about these things, that is not always the responsible decision for other units or full hospitals, or they have to think about so many other layers of that. And so, we definitely have worked with hospitals where we've had navigators, for example, that get frustrated by the extra paperwork. And that does feel like a really big annoyance. But at the end of the day, the purpose of this law was to protect patients. I love that as a reminder, because then it gives us the ability to like be tenacious, just get it done. It's not that big of a deal. The goal is to protect patients' privacy. Thank you for that clarification. I don't know that I even really understood it that well until today, but I also love to find out that I don't have to worry about it. And like if I'm admitting to my hospital and staying within my system, I don't have to do extra paperwork. That I do love. And then thinking about barriers, Rebecca, one of the reasons I brought you on today is that I know that one of our favorite things to do in webinars is to murder the validity of the urine toxicology screening. It's like one of our favorite things to do because it's not a helpful test, and it was not even invented for us. It was like not even created as a medical test. It was created as a corrections end of things test. But at the same time, the more we start to work with our outpatient colleagues and think about what the law actually says about this, I think it gets a little bit more confusing, because we hear about these rules like, well, you must actually test people for them to continue BUP, or you must for them to get outpatient care. I was hoping that you could shed some light on this for me yet again, but this time not about the validity of the test. We all hate it. We think it's a bad test, but more about what are my actual rules? Like, what are the rules? What are my obligations doing this test or not doing this test in the care of patients who have substance use disorder?
Yeah, thank you. I think one of the thing that kind of trickles down is in the methadone clinic world, there's a lot of rules and statutory prescribing around you must order this, or you have to have this many hours of this kind of service available to have a methadone treatment center. And that's not the case for buprenorphine. And when we had these X waivers, we had to fill 8 hours of content. And so we talked a lot about urine toxicologies. And I think it kind of, again, trickled into the like ether of how are we treating people with substance use disorder? And somehow there's this urine toxicology that's available and should be used because it's a tool, because it's effective. And, like we said, it's not diagnostic. It's not necessarily informative. It can, in collaboration with other information from our patients, support certain action steps. But in the emergency room in an acute care setting, it's not useful. And the challenge is often, let's say everybody, in daytime hours have received your beautiful ethics training and your beautiful stigma training. It's like you're cross-covering, brand new, somebody from somewhere else is going to cover at 2 a.m. and see a result from maybe 3 years ago, what that urine toxicology is. And let's pretend you had a patient who's now in labor and delivery, and they're like, well, you had meth positive 3 years ago. And, mistakenly kind of overinterprets that as currently using. And therefore, if you're currently using, overinterpret that as I need to call DCFS, I need to call, some sort of legal system to report you to somebody about that use. So I really just urge people to really think, one, when are we ordering tests? Two, how long is that test going to be like associated with that person? And more in electronic medical record forever, right? So, and then it's like, even if we're doing the best intention of destigmatizing things, it's always going to have that chance in this community, in this culture, in this world right now, that somebody's going to misinterpret it and cause harm to your patients. So for every test we order, there's potential benefits and potential harms, and to really think through in the world of substance use disorder that those harms are often forensic, legal, and beyond our control in the here and now. So what's going to happen in 3 years? We don't know, but let's try to make sure that what we're ordering right now is going to align with the best sense of equity and justice for our patients.
Yeah, the permanence of results in people's medical records is something that we often underestimate, the impact of 3 years later, 4 years later. Now I'm pregnant. Now I'm on labor. Like that, those things will still come forward. And so just realizing it's not just some random, like, I think that's a rule. I'm just going to order it because I think it's the rule. You should know what the rules are. And that, in particular for federal regulations, that there is, for example, no requirement federally to do urine toxicology screening for patients who are on buprenorphine, for example, or who are on naltrexone for alcohol use. Like that does not exist. And I will call out that state to state it is different. And I don't stand here and pretend that we know the rules in all 50 states, but maybe the call here for any champion is you need to make sure you know what they are. Like look up your actual state's regulations and, are you doing something that is patient-centered? And if you need guidance for what that means, like let's say that your state doesn't have any rules, the most recent recommendations that came from SAMHSA and ASAM are from 2017, and we put them in the chat, but you can also look them up. And they say in there that the role of testing is very clear, that it should be used as a tool for supporting recovery rather than a tool for exacting punishment. And so I think thinking about it that way is really critical. We are about at time, so before we do our recap, though. Rebecca, speaking of rules and regulations, you shared with me last week some really good news. And so I wanted, no matter what, to end on a positive note, which is, what is the good news that you shared with me surrounding patients with substance use disorder?
What is our good news, Alicia?
About the buprenorphine age. You just told me this last week.
Oh, the 16 plus, right. So knowing that youth can self-consent to receive buprenorphine even at 16 and 17, that's really powerful. That's in California, and it's in line with all this information that young people should be started on treatment, just like 18 plus, and more that it's available for young people to self-consent. Of course, you can involve, positive influencing adult in their life, but often when you see somebody with substance use disorder who's 16, they might not have that guardian who's really looking out for them. So it's really wonderful in the state of California that you can now provide buprenorphine to a 16-year-old. And I always just think, how often are we providing morphine to a 16-year-old or 14-year-old who broke a bone? So if you're in the acute care setting, if you're in the ER, in EMS, and you would otherwise provide morphine for a person of that age in that setting without a huge paperwork, without involving their parents, because acutely right now they're suffering, think of buprenorphine in that same category. If somebody's in withdrawal right now, if they're actively craving and about to leave AMA or do something disruptive and harmful to their life, like buprenorphine is a treatment, and you can provide that in the same way that you would do any other emergent care for that person. And then work out, like with the parent, with the guardian, with the legal court system, what the right thing to do is long term. But the wonderful thing about the ER is that it's here to provide, right now care for stabilizing all people. So it's a wonderful opportunity to provide good care for our young people, our pregnant people, our elders, all that kind of stuff.
Yeah. And if you want more detailed deep dive into, caring for youth and adolescents, we have a full hour-long lecture that goes into those laws. But I am happy to say, I will always be happy that we're outdated if it's for a positive reason, that one of the points we make in there is that you have to be 18 and up to consent to bup. And now in California, you don't. You can be 16 and up. But again, anybody 12 and up can get medication to relieve their pain and suffering right now. So it's a little bit more murky. We'll discuss that in detail in that other lecture, but we'll end with some good news on the regulatory front. We love when things move in a way that increases access to care. That's our favorite. So this was extremely dense, really different angle, not so much clinical as much as like doing our good clinical work in the midst of a very unpredictable and dynamic political and regulatory environment. But let's just recap together. So first, our patients have a right to medication-based addiction care. I think Dustin did an amazing job of highlighting that for us. We know that drug overdose kills people. It is very dangerous. It has high morbidity and mortality. The evidence, for example, for buprenorphine for opioid use disorder is overwhelming. It is the standard of care treatment. The X waiver is gone. The DEA mandates that you must do this training, and ACEP will let you bill for it. No more excuses. It is time to learn how to do this medication, how to know how to do it, and to make sure that you're offering it to your patients, that you're starting correct patients on that medicine the same way you would antibiotics for an infection, or you would give, medicine for a headache. Like, there's no more pretending this is different. It has to be the same. And so it's time to elevate our teams that way, because refusing to start MAT is literally denying our patients life-saving care, and you could be held liable for that. P.S. It's so bad. Like, it's the wrong thing to do. Don't do that. Don't be that person. Give your patients good care. Next, the right to access that care is also protected by other laws besides EMTALA, including the Americans with Disabilities Act. And so that can help you sometimes if you're trying to place a patient in a nursing home, or even like a detox, quote unquote, facility, or to a clinic to follow up. If those people are telling you, well, we don't do those medicines, you can't be on that medicine here, that actually violates the Americans with Disabilities Act, and is an opportunity for us to collaborate with that receiving entity and say, I'm concerned that might violate this law. What are the concerns you really have? And can I help support you to success to continue caring for our patient together? When it comes to immigration or immigration officials, first and foremost, lesson from Elena, stay calm. We are not seeing the widespread ICE raids of hospitals that some people were worried about. It just isn't really happening. But it could still happen. I mean, legally, lawfully, it could. And so it is important to know what to do and to be thoughtful and prepared about that, namely so that you, the clinician, can do your job, which is good clinical care for every patient every time. Make sure you know the difference between public and private spaces in your hospital. Make sure you know who the point person is in your hospital, who is literally the expert trained in dealing with this situation, because that's not what I was trained to do. And so the minute that we can respectfully comply with the law, but defend our patients and their medical care, that is our job, is to provide excellent high quality care. So to make sure that you know that process, and then think about that when it comes to patients who are here with any kind of law enforcement. Patients do have a right to talk to us privately, to disclose any details of their medical care without being worried that the person at their bedside is gonna, write that down and prosecute them for that. So it's important that we know our job as clinicians is clinical and only clinical, and find ways to honor that privacy with our patients. Next thing, part 2 compliance. If you're still worried about it, just ask your hospital, your receiving clinics, like, what is their current policy around it? And if your receiving facility, et cetera, has decided that they need to be part 2 compliant, just be tenacious, get out there, get that paperwork done, figure it out. But know that for you in the emergency department, not relevant in real time, hallelujah. But we are not risk averse people, and it's important to honor, the advice of the council of our hospitals and what they've determined is the right thing as far as making patient referrals. And then when it comes to your toxicology screening, they are not legally mandated at the federal level. You do need to make sure that you know the rules at the state level, but always being cognizant of how are you actually using that test. And if you don't need it, don't order it. Just like if the person's citizenship is not relevant, don't ask. There are downstream effects to everything we do in healthcare. And the more we can just focus on our job, which is bedside clinical care, and let all the rest of it be noise that is not our number one priority in that moment, where we're bonding that physician-patient relationship, the better job we'll do providing care, and actually the more protected our patients will be with our advocacy and our care. And then finally, great news. If you're in California, patients 16 and up can now consent to their own buprenorphine treatment, which is just really exciting. So I want to say another just massive thank you to our speakers today, to Dustin and Elena and Rebecca, for shedding these insights and their own ways of thinking about things that are certainly different than my own. And it just reminds me of this quote from Maya Angelou: do the best you can until you know better. And then when you know better, do better. And that's how I feel learning from all of you. Now that I know better, I have things that, my little marching list of action items, I can go back to my hospital and talk about them so that we can do better for our patients and protecting their privacy. If you want to see any of our clinical information or access our previous trainings, you can head to our resources page. We also have our California Bridge Academy. I mentioned our youth and adolescent lecture, for example. Those are all available to you for free for any clinician across the nation. These are free for you and CME approved with AMA Category 1 credits. Please access that through our academy. And if you have any questions or want to reach us, you can go to info@bridge2treatment.org. And we would love, 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 love always to hear from you. Big or small, whatever your concerns are, let us know. And as we always end by saying, I genuinely want to thank you for everything that you are doing to help us save lives. Thanks, everybody.